Good morning and welcome to my YouTube channel Pain Free Partha. And today's talk is about post-herpetic neuralgia. And I'm also going to tell the basic things and some advanced treatment with my protocol. Okay, listen to this Pain Free Partha. So a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, and our institute Mahatma Gandhi Medical College and Sri Balaji Vidyapeeth. Now we will go into what is the definition of this. Post-herpetic neuralgia is a neuropathic pain. Now it is not nociceptive pain, very important. It is a neuropathic pain. It is caused by herpes zoster and a reactivation of this. And in the dermatome, the pain is there in a neuropathic way. And it persists after 4 weeks after the onset of herpes zoster. This is what is the definition of post-herpetic neuralgia. Now I will go to the course. Okay, for example, a patient has got a varicella zoster or the chicken pox at the age of 5. Okay, now he is gone into the age of 65. He develops some immune compromise and he develops herpes zoster. There is a reactivation of the virus. This herpes zoster produces clumps of erythematous patches with vesicles. Pain, severe pain, allodynia, everything happens, rashes, then slowly heals, and over a dermatome, it causes severe pain which persists for 4 weeks or more. Then it is called a post-herpetic neuralgia. A vague case, intercostal neuralgia, the symptom did not get controlled. He went to the court against the doctor saying he cannot roll down in the cart and he cannot hug his son. Not it. So another case which I had found, a 55-year-old female, she had chest pain. So ECG was taken. As usual, ladies know, ECG was taken. It showed some SCT changes, and she was diagnosed as ischemic heart disease, and she was given isodil, beta blockers, aspirin, and all. Then suddenly one day I saw that this thing, there was a herpes zoster healed lesions. Then I went into the history. This patient had CA cervix. Now again, I'm going to the course. Possibly she had got chicken pox at the age of 10 or 11 or 8 or something. And she has developed a CA cervix at the age of 55. That has caused an immunocompromise. That has caused a reactivation of herpes zoster. And the zoster has healed with PHN, post-herpetic neuralgia. It sleeps on the DRG, dorsal root ganglia, usually restricted to one dermatome, and very fragile, immune depleted, can affect multiple dermatomes. So probably there is some immunity. So that is why it is affecting single dermatome. There is complete immune deficiency. Herpes zoster can come also into multiple dermatomes. So reactivation of the thoracic DRG here this is and goes off. These lesions heal off and slowly pain sets in at 4 weeks. Severe pain, neuropathic pain. There is something called zoster sine herpetic, means there is no rash, but you can see the herpetic pain. There is no rash, intercostal severe pain. If you go, there will be an antibody titer and you can see CS of DNA. So this means this patient has possibly got herpes zoster without a rash. That is what is called zoster sine herpetic. Further research has been done in this about many things. So herpes zoster, the annual incidence is 11 per 1,000, high incidence. That is what I wanted to emphasize here. This is a post-herpetic neuralgia is a common condition and this is not treated aggressively in our place. So this is not treated aggressively. Patients are in pain for years together. 10% goes into PHN and 20% 65 and 30% above the age of 80. So that means what matters mainly is the age. Number 2, there is an immune compromise. These two things make a reactivation of the herpes zoster and make them prone for post-herpetic neuralgia. PHN tends to fall in the number of phenotypes. Many types can co-present. Constant pain without a stimulus, burning, itching. Intermittent pain without a stimulus or an evoked pain. Anything can happen. but it is neuropathic. There is no nociception. Post-herpetic neuralgia causes considerable suffering and results. Individual and society, because this patient at the age of 60 has severe pain, goes, takes some drugs and sleeps, quality is gone, society is affected by this. Physical functioning is affected and psychological well-being is also affected. So it is underdiagnosed, inadequately managed, especially in primary care settings, even in big developed countries. So susceptible to degeneration with subclinical women are more prone. Pain or abnormal sensations before the rash, severe pain, sometimes ophthalmic involvement also. Additional possible risk factors are systemic lupus erythematosus, diabetes, or a recent trauma. Commonly we get diabetes. Patient develops herpes zoster. It will not continue to flourish for decades. It is very difficult to treat. The pain remains, but pain slowly goes off by 3-4 years and vanish. Varicella reactivation in a single DRG is based on two related: unilateral dermatome of symptoms and pathological observations on the nerve fibers on the sensory null somata. Now we have one thing is unilateral things, another thing dermatome level, another thing is there the DRG has got problems, inflammation in the sensory cell somata of dorsal root ganglions. There is a cutaneous inflammation. There is very rarely virus-induced sensitizes nociceptor. Even though it is a neuropathic pain, there is rare deafferentation of the sensory neurons. Some ectopic focus means the place it is not usual. It is not the stimulus. Now we can see this is the place where you have got a nerve damage or zoster has occurred and gone. There are free nerve endings which has got affected. There is an ectopic focus coming and producing pain. There is a peripheral sensitization and that causes increased discharge. There is a spinal deafferentation that causes bad things. So there is an increased ascending pain path. This is one. Number two is the always the pain are decreased by descending pain controls, but this is lost. So descending pain pathways don't inhibit. So this red becomes more. There is also a central sensitization here and also some part here. So that means all these things put together in the pathophysiology of post-herpetic neuralgia. Now we know herpes zoster followed by PHN followed by pain, neuropathic pain, slowly waits off by 2 to 3 years. Yes, but it is severe, debilitating, societal problems, psychosocial problems, so many things. Depression, fatigue, disturbed sleep, lack of appetite, impaired concentration. So all these things put your diabetes to risk. That is very important. Depression, fatigue, disturbed sleep, all these things put diabetes into uncontrolled because these patients are most often diabetic. So that is why we need to treat PHN effectively and aggressively to control diabetes also. Now we know that these are the problems. How do you prevent this PHN? You have to vaccinate the child in adult live attenuated shingles vaccine. Now, if we prevent herpes zoster, how we will get post-herpetic neuralgia? Now, we are vaccinating for chickenpox. So, the vaccine is there. So, herpes zoster is not coming much. So, if the herpes zoster itself is not coming much, how can it be an incidence of PH? There are a lot of other things which causes decreased side effects. So many different subunits of herpes zoster vaccines. So if now herpes zoster we have prevented, that is the first step. The second step, herpes zoster has occurred. How are you going to prevent PHN? Okay. Prompt treatment on the day. I usually tell when the patient gets herpes zoster, I go to the medical shop, give him acyclovir 100 milligrams, 800 milligrams, ask him to take immediately in front of me. So because the first dose as early as possible decreases the incidence of post-herpetic neuralgia. So, but the results are inconsistent. What I feel is you have to use antiviral medication as early as possible. If you use after 4 weeks, there is no use. Now, this is what we have known. What is post-herpetic neuralgia? It is a neuralgic pain or a neuropathic pain which occurs in a dermatome level after a herpes zoster. 4 weeks later, persistent. Okay, it can occur in the thoracic, it can occur in the sacral, it can rarely occur in the limbs, or it can occur even in the ophthalmic, trigeminal. This is about the incidence is about 11 by 1000 for herpes zoster and 10% go into post-herpetic neuralgia. That means you see around 1 in 1000. If it is going to be old age, it is going to be 30%, means 3 in 1000 go into post-herpetic neuralgia. It is underdiagnosed and it is undermanaged even in big countries. So this is a disabling disease which comes with immunocompromise like CA or diabetes or systemic lupus erythematosus. How to prevent this? We know herpes zoster prevention by vaccination or a prompt first dose of your antiviral drugs. So gabapentin, pregabalin, so many drugs. Topical 5% liquid. These are opioids. Tramadol, methadone, morphine, oxycodone, capsaicin patch. I will tell 3 main things. Number 1 is gabapentin, pregabalin group, which are calcium channels. And tricyclic antidepressants are nortriptyline and desipram. Topical lignocaine, topical capsaicin. The next is opioids. These are the 4. Number 1 is gabapentin pregabalin calcium group. Number 2 is topical 5%. And other group is tricyclic antidepressants, capsaicin, opioids. They say it is 300 milligram twice or thrice a day, can go up to 1800 milligram. But what I feel is you start with 300 milligram in the night. That itself will cause the patient to wake up at 9 a.m. and 10 a.m. So we should be careful to the patient, telling that this patient will not get up till 12, gary, dizzy, all these things will be there. Don't worry. The drug, the actual neuropathic pain decreasing effect may start after 1 or 2 weeks also. That is what we should make. The sleeping, sedation, all these things will start immediately. But sometimes the anti-neuropathic pain effect of gabapentin or pregabalin may start a little later. That is why we should pursue the drug even of side effects. Just decrease the dose if you want. It is not palatable or it is not tolerable. Because if you stop gabapentin and again after 1 week you start, the action may be still slower. Nortriptyline 25 milligram HS twice a day. 50 milligram is available. Amitriptyline, sedation, weight gain, and dry mouth. And caution in the elderly because of heart diseases. Because all these things are tricyclic antidepressants. Very important. So there is some sort of BP rise, some sort of tachycardia may be there. And glaucoma may be precipitated. Dry mouth may be there. So these are the problems of tricyclic antidepressants. We have serotonin, SNRIs like duloxetine. We start with 10 milligram HS and go up to 30 milligrams BD. Venlafaxine is also there. So now we have 2 drugs. Gabapentin group, 300 milligram HS. Pregabalin, 75 milligram HS. This is the dose. Okay. The second group is TCAS, amitriptyline 25 milligram HS or nortriptyline 50 milligram HS. This is the second dose. Third drug is opioids. We have used a lot of opioids, tramadol and this thing, tapindalone. So here there are so many receptors involved in the genesis of post-herpetic neuralgia. So all these things can be targeted. Now you see capsaicin creams. Duration of treatment with single application of 8% patch is available. It is a TRPV1 activated. What it happens is it depletes substance P from the nerve endings. Substance P is an algogen. Substance P is a pain producing substance. Your capsaicin will completely deplete your substance P, so there is no pain. But there is a small irritation at the start. So what I do is start with a lignocaine patch, then apply your capsaicin. So this initial irritation by capsaicin will not be there. Still, it is effective in depleting 5% the substance speed, and it is effective. We can use 0.15 milligram of IV ketamine as a single dose. Flupertine 100 milligram BD. So what we target is antagonism of NMDA receptors. Topical 5% lidocaine is the third level in Canadian guidelines, which also add tapindalol. It is the next generation of tramadol, but it is commonly come as in 50 milligram and 100 milligram tapindalol. I use 50 milligram HS and then give 50 milligram BD in the afternoon and night. It is slightly sedative. Post-herpetic neuralgia received a cream containing cannabinoid receptor agonist. Okay, effective. So cannabinoid receptors are also involved. Lignocaine patch is applied once daily, 12 hours, then 12 hours removed. Total of 3 plasters can be used. Lignocaine hydrogel plaster provides immediate cooling sensation and acts as a mechanical barrier. So it is not that the first lignocaine is effective. Lignocaine cools. Thereby again I am telling you the gate control theory, pain is decreased. So first lignocaine patch acts by a mechanical thing and then goes to act in a chemical way. Now, the first line of treatment is anticonvulsants, lignocaines, and TCANs. The second line is opioids and topical capsaicin. The third is refractory, means we may need to, usually this thing is around 6 weeks. 6 weeks, if it is not responding much, definitely we may need to go for these type of drugs or treatment. Nortriptyline, what I do is nortriptyline pregabalin combination with low dose steroids. I stop these steroids after a few days. Add flupertine. If that is not going well in first 3 to 4 weeks, I will give a trial block with LA and steroids and then add alcohol or phenol. So that is how sometimes I may need to repeat after 3 months. Acupuncture is very effective. I've done a lot of cases. Acupuncture is very effective in neuropathic pain. What are the other treatment modalities? We can target the sodium channel like here. So these receptors are involved in chronic pain processes. They express in CNS and PNS. The blockers have been successfully tried in trigeminal neuralgia. Angiotensin receptor antagonist, the new drug EMA 401. Botulinum toxins also as a third line treatment because of its possible anti-neuropathic effects. There is not much of about TENS or acupuncture, but I feel this is a wonderful method of targeting post-herpetic neuralgia. Vitamin C have been described. Cognitive behavioral therapy has been described. Evaluation of efficacy of ultrasound-guided alcohol-based neuro and observational study by us. This is by us. So wonderful. Just see the ribs. This is the pleura. Here you see the lower border of the upper rib, just intercostal nerves are there, pleura is there, and drop the local anesthetic with alcohol here. We can also target the autonomic nervous system. So there is small somatosympathetic link. So management of sacral post-herpetic neuralgia, how to do? Very difficult to do acupuncture also. So I thought we will do an assault block, and this was published in this journal. With there is also I have done to L1 nerve. Here you can see the L1 nerve. Here L1 means this is groin, and here there is a herpetic neuralgia. Post-herpetic neuralgia with transverse abdominis block. I gave 2, and then completely the pain decreased. We don't know whether it is neuropathic effect or not, but there is some block of some nerves which makes the pregabalin to act. That is what I felt. Pulse radio frequency treatment is segmental gas, pain practitioners, neuroablative technique. High frequency current, short burst. This is what is called PRF. So we need to know awareness about the management. What is this Quirik-Julie effect? When celebrities share their medical experience. Amitabh Bachchan comes and tells, I have severe post-herpetic neuralgia here. I cannot tolerate. Somebody gave this drug. I am fine now. Somebody put acupuncture. I am fine now. Somebody gave neurolytic block. I am fine now. This celebrity makes the management of PHN worldwide famous. This is called Curie-Julie effect. So what is the definition? I have told. It's a neuropathic pain after a herpes zoster, persistent after 4 weeks. Usually resolves by 3 to 4 years. When and where? When we know where it may be intercostal, it may be lumbar, it may be sacral, it may be ophthalmic. Risk factors are old age, immunocompromise, possibly diabetes or malignancy. Prevention, treat doesn't have herpes only because you give the vaccine. Number two, treat the herpes zoster very actively. Strike hard in young patients, go slow in old because 300 milligram gabapentin if you give it for an 80-year-old person, soon at 2 o'clock, night 2 o'clock, you will get a call from the attender that the patient is unconscious or some bad, he is doing something. So go slow in old patients with all these not repelling drug because he may get urinary retention. All these problems will come. So strike hard in young patients, go slow in old patients. None bothers about this champion who's a motorbike in the midst of cricket storm. So in the era of atherosclerosis, dyslipidemia, early stroke, impending stroke, also think of pain as a suffering. Divinum estopus sedere dolorum. Decreased pain is divine. Thank you all and visit my pain-free Partha YouTube channel and subscribe. Thank you very much.